بسم الله الرحمن الرحيم. First of all, I would like to thank Professor Mariam, Professor Mustafa, and Professor Nagdi Bordil for inviting me to share in their annual meeting and congratulate them for successful meeting, inshallah. Give me honor and pleasure to co-chair the session with Professor رجب. في بس يعني النص كده عايز اقول اسمحوا لي يعني هتطفل على المؤتمر حاجه مهمه للجامعه كلها. يوم الجمعه الجايه 30 في انتخابات مجلس اداره نادي اعضاء هيئه التدريس في الجامعه في الشاطبي. انا بقول الكلمه دي بس علشان احنا عايزين اكبر عدد ممكن من اعضاء هيئه التدريس يروح ويشارك في الانتخابات بغض النظر عن الاختيارات، علشان يبقى مجلس اداره النادي ممثل حقيقي لاعضاء التدريس ويقدر يقوم بوظيفته. انا اسف ان انا يعني عملت لكم انترابشن. The fifth session of the conference is titled Infertility. We have four speakers. May I call the first speaker? First speaker is a dear colleague and a friend from Department of Obstetrics and Gynecology in Alexandria. He is Professor Muhammad Murad Al-Abd. Will address us about anti-malarial hormone and female fertility.
First of all, I want to thank all my colleagues in the Research Department, Clinical Consortium Department, for inviting me in this very nice conference. The anti-malarial hormone and female fertility. What is anti-malarial hormone? Anti-malarial hormone or malarial inhibiting substance is a homodietary glycoprotein factor belonging to tumor beta family. It is a large glycoprotein with a molecular weight 4 times larger than FSH and LH. Anti-malarial hormone is a diagnostic marker for ovarian cancer. The clinical significance of anti-malarial hormone has 48 been limited to the critical role in fetal sexual development. What is the gonadal origin of anti-malarial hormone? In males, anti-malarial hormone is produced initially by circulatory cells during fetal sexual differentiation. The circulatory cells produce anti-malarial hormone. This is inhibitory to the Müllerian duct, so inhibiting the products of Müllerian duct, which are the uterus, the tubes, and the vagina. While the testosterone is from the Leydig cells, this is stimulated to Wolffian duct, so it produces the seminal vesicle, epididymis, and vas. The testosterone is then converted by 5-alpha reductase to dihydrotestosterone, leading to masculinization of the external genitalia. So the testosterone makes the baby in utero masculine, and this is with the help of anti-malarial hormone. In females, granulosa cells from primary and pre-antral follicles produce anti-malarial hormone only after birth. It is not detectable in serum at birth, and anti-malarial hormone is reliably measured as reproductive potential is reached. Anti-malarial hormone was first demonstrated to be present in the follicular fluid in women undergoing in vitro fertilization, suggesting that it has autocrine role in follicular maturation. In human antral follicles measured 6 mm and less express the greatest amount of anti-malarial hormone, but as follicles of 8 mm, theca cells, atretic follicles have undetectable levels. So, is there any connection between the anti-malarial hormone and ovarian aging and ovarian reserve? In a prospective study of 41 normal ovulatory women, the mean age was 29 years. The follow-up with for 1 to 7 years, they noted a 38% decline in serum day-3 anti-mullerian hormone levels from 2.1 to 1.3, despite of absence in the internal change of number of targets of serum concentration. So the anti-mullerian hormone is coming a very, very good indicator of ovarian aging and ovarian growth. In another study, which was done on 81 women, the age was 39 years, they are 10 years older than the previous study. Over an interval of 4 years, noted a mean day-3 serum anti-mullerian hormone decline by 58% from 1.2 to 0.5 nanograms per ml. Anti-mullerian hormone, Van Roy demonstrated and that the anti-mullerian hormone, the most consistent change with antral peripheral count, and was the only marker to demonstrate a mean longitudinal decline over time compared to serum FSH, E2, and insulin. So is there any relation between anti-mullerian hormone and weight? Freeman made a follow-up of healthy productive age women. The age was 45.8 years, obese and non-obese women, over 8 years, and noted significant inverse association between anti-mullerian hormone and BMI. Obese women had 65% lower mean anti-mullerian hormone. So when to assess the anti-mullerian hormone? Unlike the conventional early follicular phase markers such as FSH, inhibin, and E2, anti-mullerian hormone CBER levels appear to be independent of gonadotropin stage of pregnancy. Minimal variation of anti-mullerian hormone through the menstrual cycle was confirmed in 4 clinical studies. So we can measure anti-mullerian hormone anytime during the cycle. Is there any association between anti-mullerian hormone and ovarian response? Lamarck demonstrated that anti-mullerian hormone serum sample on any date of the menstrual cycle predicted ovarian response in vitro fertilization. Data from 48 women, 28 in the follicular phase, 20 in the luteal phase, revealed lower anti-mullerian hormone associated with increased cycle cancellation and fewer oocyte peaks. This means that less than 4 oocytes per repeat. Again, using the anti-mullerian hormone threshold value of 0.8 nanograms per ml, the sensitivity was 85, specificity 82.3, is predicted for response. So if I have this cutoff limit of anti-mullerian hormone, and I'm doing an IVF cycle, this means that the response will be poor, and also the result will be poor. So, is there any relation between anti-mullerian hormone and oocyte quality? Amber prospectively examined oocyte in 141 women undergoing ICSI and noted higher serum anti-mullerian hormone level associated with better oocyte appearance. Best quality oocyte were associated with median anti-mullerian hormone of 1.66 up to 4.52 nanograms per ml. So cutoff limits now are evident to determine the results of in vitro fertilization. Is there any relation between anti-mullerian hormone and embryo quality? Silberstein found embryos of better morphology and cleavage with mean anti-mullerian hormone 2.7 than below this level threshold. Is there any relation between anti-mullerian hormone and ovarian hyperstimulation syndrome? Makuta noted that the baseline of serum anti-mullerian hormone is 6 times higher in patients with ovarian hyperstimulation syndrome than those with normal responses to anticoagulants. Is there any relation between anti-mullerian hormone and PCOS patients? Elevated serum anti-mullerian hormone levels in PCOS is apparently not restricted to adult women. Adolescent girls with PCOS have elevated serum anti-mullerian hormone values when compared to control subjects. Also, metformin reduces serum anti-mullerian hormone levels in women with PCOS, thus further supporting the association between the pathogenesis and the pathogenesis of PCOS patients. This work was done in Shafii Maternity Hospital in the IVF centers. This is the work of our colleague Hisham Adel, supervised by Professor Amal Darwish, our chairman, and analysis was done by Professor Magdi Al-Barkini. The aim of this work is to evaluate the efficacy of anti-mullerian hormone as an indicator of ovarian reserve, and to evaluate the relationship between its level in the follicular fluid and the maturity of the retrieved oocyte in patients with and without PCOS undergoing ACS cycle. 80 patients were divided into two groups. Group 1 included 40 patients not suffering from PCO. Group 2, 40 patients suffering from PCOS patients. I will jump about the inclusion and exclusion. The material method. On day 3 of the menstrual cycle, vaginal ultrasound was performed to assess the number of antral particles, measuring 2 to 5 millimeters, and blood samples was obtained, and serum E2, FSH, and anti-mullerian hormone were measured. Patients in both groups had typical suppression long agonist protocol. This was continued until the day of the administration. Group 1 had 300 interventional units to induce ovulation, while group 2 is a PCOS patient, is a good responder, so that we have decreased the dose to 150 to 300 international units. Patients who appear to be liable to develop severe ovarian hyperstimulation syndrome, evidenced by high E2 levels above 5,000 picogram per ml, were managed without withholding gonadotropin dosing till the E2 level decreased to a safer point. Follicular fluid excreted from the large 2 to 6 follicles was transfused, and sample was frozen at minus 20 degrees centigrade for later measurement of follicular anti-mullerian hormone. When we compare the two groups as regards age, nothing difference between the two groups as regarding age. When we compare both groups regarding the number of gonadotropins, the first group, the non-PCO group, used significantly higher number of gonadotropins compared to the second group. We have started with 300 and international units, here 150 to 300, that's why it is significantly higher in the first group. As regards comparison between the two groups regarding beta E2, no significant difference between two groups as regards the beta E2. No significant difference between two groups regarding the FSH, measured day 3. As regards the antral-particle count, of course, the antral-particle count in PCOS patients, which is the second group, was higher than the first group. When we compare follicular anti-mullerian hormone, there was no significant difference between the groups, but serum anti-mullerian hormone was significantly higher in the PCOS patients. Comparison between both groups as regards the oocyte number. Of course, PCO patients have significantly higher number of oocytes and significantly higher number of mature oocytes, but the percent of mature oocytes was higher in group 1. The number of embryos is higher in the PCOS patients. In all means we have more oocytes, more M2 oocytes, so it's very logical to have significantly higher amount of embryos in this group. When we compare the incidence of ovarian hyperstimulation syndrome, no significant difference between both groups as regards ovarian hyperstimulation syndrome. As regards the need of posting group, the PCOS patients, so significant patients, PCOS patients needed posting more than the other group. As regards the number of embryo transfer and number of gestation sac number and the implantation rate, no significant difference between both groups in these parameters. As regards the comparison between both groups in pregnancy or ongoing pregnancy, no significant difference between both groups regarding pregnancy or ongoing pregnancy. There was a positive correlation between antral-follicular count and the beta anti-mullerian hormone in group 1, group 2, and in all patients. Correlation between the number of oocytes and E2, FSH, and antral-follicular count, serum anti-mullerian hormone, follicular anti-mullerian hormone. There was a positive correlation between antral-follicular count and serum anti-mullerian hormone in group 1, group 2, and in the whole study group. As regards the prediction of need of boosting, in group 1, antral-follicular count was a good predictor of boosting, while E2, FSH, and serum anti-mullerian hormone were not. In group 2, antral-follicular count and serum anti-mullerian hormone were positive predictor, while E2 and alpha test were not. When the whole study group was added together, we found that the intrafollicular count and the serum anti-Mullerian hormone were good predictors. As regards to prediction for ovarian hyperstimulation syndrome, intrafollicular count and serum anti-Mullerian hormone were good predictors in group 1. In group 2, only intrafollicular count was positive predictor. When both groups were added together, intrafollicular count was the only predictor. As regards to prediction of pregnancy, intrafollicular count and serum FH were good predictors in group 1. In group 2, none of the parameters were predictor of pregnancy. When we put both groups together, the whole study group, intrafollicular count was only predictor of pregnancy. As regards to prediction of pregnancy, intrafollicular count was good predictor together with serum and anti-Mullerian hormone in group 1. In group 2, none of the parameters were predicted. In group 1, we put both groups together. The intrafollicular count was the only predictor of pregnancy. To conclude, serum anti-Mullerian hormone is a good marker of ovarian research, superior to E2 and follicle stimulation hormone, and comparable with the intrafollicular count in both PCOS and non-PCOS patients. Serum anti-Mullerian hormone is not only correlated with the number of oocytes released, but also the number of mature oocytes released. Serum anti-Mullerian hormone is a good predictor of ovarian hyperstimulation syndrome. Thus, it can be used in calculating dose used in controlled ovarian hyperstimulation before consistent treatment. Anti-Mullerian hormone is very closely correlated.
Your time is up.
With intrafollicular count can be added to the diagnostic criteria of PCOS. Follicular anti-Mullerian hormone is not correlated with the number of oocytes retrieved, not the number of mature oocytes retrieved. No ovarian reserve marker is significant to predictor of occurrence of pregnancy, and certainly not ongoing pregnancy, and certainly not of ongoing pregnancy because of multiple interplaying factors affecting spinal outcomes. Thank you very much.
Thank you, Professor Muhammad. I think we will keep discussion after the second presentation.
First of all, I would like to thank the organizing committee of this conference and the department head of the clinical pathology and all our friends and members of the clinical pathology department for this nice scientific and social meeting, so that we are meeting friends and all in the field of clinical pathology in Alexandria. And so it's a pleasure for me to introduce Dr. Tarek Hussein for the next talk. It will be on sperm DNA integrity and male protein.
بسم الله الرحمن الرحيم. رب اشرح لي صدري ويسر لي امري واحلل عقدة من لساني يفقهوا قولي. بحب اشكر اللجنه المنظمه وحتى الدكتوره مريم للدعوه الكريمه ديت، وان شاء الله نتكلم عن موضوع جديد شويه، السبيرم دي ان ايه وعلاقته بالاسيستد ريبرودكشن. هنتكلم عن شويه حاجات جديده ظهرت. طبعا ده المنظر الدي ان ايه اللي احنا عارفينه، الدبل هيلكس المعروف، الاي والتي والسي والجي. طب المولكيولر ستراكشر بتاع الدي ان ايه دوت كان اتعرف سنه 1953. الدي ان ايه اللينس بتاعه لو اتفرد بيدي تقريبا 1 متر. 1 متر دوت بيتلف بطريقه معينه او بيحصل له فولدنج بطريقه معينه عشان يوصل في الاخر ل 10 مايكرو متر دون. ازاي؟ احنا عندنا هنا اهوت ال 2 نانومتر دايمتر دي ان ايه دوبلكس يبتدي يلف على شريط البروتين دي اللي بنسميها الهيستون عشان تدينا دايمتر 11 نانومتر دايمتر هيستون. الهيستون بتشبك مع بعضها ان فورم اوف اوكسمار تدينا بعد كده هو المنظر بتاع الكروماتين فايبر الدايمتر بتاعه 30 نانومتر. بيحصل له فيرزر كويلينج عشان يدينا كروماتين فايبر، بيحصل له فيرزر كويلينج اوف ذا كويل بيدينا في الاخر اللي هو المنظر بتاع الكروموزوم الميتافيز. يعني سبحان الله 1 متر لونج دي ان ايه بيحصل له فولدنج على ذيس بروتينز وبيحصل له فيرزر فولدنج عشان في الاخر يوصل لذيس لاس. لكن الدي ان ايه موجود في الشكل دوت في السوماتيك سيل. مختلف تماما اللي بيحصل في السبيرم سيل. السبيرم سيل المساحه ضيقه لوجود الكروموزومز او وجود الدي ان ايه. بيحصل تشينج ان ذا كارير بروتين، بيحصل ريبليسمنت بروسيس ستون وبروتين تاني بنسميه بروتين. Unlike the chromatin structure of somatic cells, sperm chromatin is very tightly compacted. ده السوماتيك سيل احنا شايفين هنا بنلف على الهستون. ان هو بيحصل ريبليسمنت للبروتامين، البروتامين دوت بوزيتيفلي تشارج بروتين بيتلف عليه اللي هو زي بيدينا بشكل زي الانيوس او دونت عشان يبتدي يشغل المساحه الضيقه اللي موجوده في السبيرم هيد، وبيبتدي يحصل برضه كلوز association between the protein علشان تعمل more compacting in the side of the sperm head. Introduction of glutamine in the sperm nucleus allow DNA strand to form toroidal or donut-shaped structure, facilitating the tight compaction of sperm nuclear head. بيحصل further disulfide cross-linking between the cysteine-rich glutamine to allow further compaction. طبعا الوظيفه الاهم بتاعت السبيرم حصول فيرتلايزيشن، بيشتغل كانه تاكسي او عربيه شايله الدي ان ايه عشان توصله للفوروسايت عشان تعمل فيرتلايزيشن تعمل لنا امبريو. الدي ان ايه بريكس المشاكل اللي بتحصل في الدي ان ايه ليها علاقه مهمه جدا بحصول الفيرتلايزيشن، وليها علاقه مهمه بحصول الابورشن، ليها علاقه مهمه جدا بحصول الانفيرتيلتي. Fertile men with normal semen parameter uniformly have low level of DNA breakage, whereas infertile men, especially with abnormal semen parameter, have increased DNA damage. Moreover, 8% of infertile men having high level of DNA damage despite normal routine semen analysis. لو عندنا مشكلة في الانفيرتيلتي ومش عارفين سببها بنسميها idiopathic infertility. Unexplained infertility لو وصلناش للسبب، لو لقينا semen parameters normal. ده مش معناه ان مفيش عندنا DNA ده مش موجود، ممكن يكون السيمن اناليسيس لو بنستعمل 99 او بنستعمل 2010 نورمال، لكن بنعمل دي ان ايه انتجريتي بنلاقيها فيها دامج. هنتكلم عن الموضوع ده واهميته دلوقتي. Sperm DNA integrity is essential for the accurate transmission of genetic information. Any form of DNA damage may result in male infertility. The clinical significance of this assessment not only in the natural conception but also in assisted reproduction. 30% من patients seeking ART عندهم high rates of sperm DNA breakage. Until now, especially in Egypt, very few clinics have implemented routine DNA integrity testing. ايه هي التكنيكس اللي ممكن نعمل بيها DNA integrity testing؟ في تكنيكس كتيرة هنعدي عليها بسرعة. أول تكنيك اللي هو التانل اساي أو ternal deoxynucleotide transferase mediated end labeling، بيعمل enzymatic addition of labeled nucleotide على end of the DNA breaks وبعد كده بيعمل لها detection. في عندنا single gel electrophoresis او COMET assay، بنعمل electrophoretic mobilization of deproteinized nuclei resulting in image of comet. الكومت دي بتتقاس حاجه زي ستار شهاب ليها الديت بتاعها بتتقاس till moment according to the density and the length of this tail. في عندنا sperm chromatin structure assay. السبيرم سيل بتبقى incubated with acid solution وبعد كده بنعمل لها staining with the acridine orange. red fluorescence لو في حصل DNA breakage. green fluorescence لو انتاج DNA. في عندنا sperm chromatin dispersion assay or بنسميه الهالوسبيرم. spermatozoa incubated in inert agarose microgel slide incubated in HCl عشان نعمل denaturation للديفيجمنتد DNA، وبعد كده هو بنعمل لايسنس للنورمال DNA بيعمل هالو. كل ما الهالو حوالين السبيرم كانت كبيره كل ما كان السبيرم ده نورمال. من التستات الموجوده والايزي تو دو ناوديز وموجوده على مستوى واسع في الريسيرشز. ده منظر النتيجه بتاعت الكون الاساسي. هنا بنشوف الابوتوتيك سبيرمز، هنا بنشوف لايف سبيرمز، هنا الهالو سبيرم، هنا ده نورمال سبيرم، هنا هو ده ابنورمال سبيرم. كوميت اساي، هنا التيل بتاعه بنقيسه بالتيل مومنت. نخلي بالنا برضه according to sperm chromatin structure assay لو ان دي ان اي fragmentation يعني percentage of the sperms اللي فيها دي ان اي damage التوتال سبيرم لو اعلى من او يساوي 30% the probability of the viable pregnancy extremely low. عشان كده بيقولوا في ايسبرج افكت او نظريه جبل الجليد. طب ليه 30% بس من السبرم افكتد وبتاثر على الفيرتلايزيشن؟ بيقولوا ان هو السبرمات لو عدد 30% دي ان اي فريجمنتيشن اندكس اللي بيحصل changes cannot be detected laboratory، ما نقدرش نعملها ديتكشن باللاب، موجوده في الاذر سبيرمز بتاثر على الفيرتلايزيشن. الكلام ده مهم جدا. طيب الدي ان اي انتجريتي اند اسيستد ريدكشن، هل في علاقه ما بين الاسسمنت والدي ان اي انتجريتي اند اسيستد ريدكشن؟ لقوا ان في علاقه مهمه جدا ما بين الفراجمنتد دي ان اي والدي ان اي فراجمنتيشن اندكس بالفيرتلايزيشن والامبريو كواليتي والبلاستوسيست والامبلانتيشن ريت، لكن ما لكوش علاقه ما بين الدي ان اي انتجريتي والبريجنسي. ليه؟ ما وصلش ايدك ان انا بايظ في الموضوع ده. انا لما بحقن 10 اوفوسايتس و10 سبيرم بعد كده بعمل سيلكشن للبيست امبريوز، يقولوا ان انا لو ما عملتش السيلكشن للبيست امبريوز هلاقي بعد كده ان في بوزيتيف كورليشن بين دي ان اي انتجريتي اند بريجنسي. امتى دي اسسمنت اوف دي ان اي انتجريتي مهم؟ في الناس اللي عندهم بريفيوس cycles failure, female with poor prognostic criteria such as advanced age, poor response, implantation failure, poor embryo quality previous cycles. مهم جدا برضه دي ان اي انتجريتي. لو انا محتار العيان اعمل له اي او اعمل له اكزي، ممكن اعمل له دي ان اي فريجمنتيشن اندكس. لو لقيته اعلى من 30 لازم اعمل له اكزي. ده كمان بقى في بيبرز جديده طلعت، لو لقينا دي ان اي فريجمنتيشن اندكس في السيمن اعلى من 50% ان هو يستحسن ان انا اعمل تستيكلر بايوبسي واخد من تستيكلر تيشو. طب كل التستات اللي احنا قلناها ديت بتشتغل على السبيرم بعد ما اقول ما بتشتغلش على الفيروس. How can we select sperm with high DNA integrity in assisted reproduction؟ في بيبرز اتعمل كتير على الموضوع دوت. لنا بيبر عملناها انا ومع الدكتور علي العقيلي والدكتور محمد العبد والدكتور محمد الصاوي، بيبر اتنشرت في اندرولوجيا وترشحت لجائزه في الرويال ريسيرش انستيتيوت. The effect of repeated sequential ejaculation in sperm DNA integrity. في ملاحظه كنا بنلاحظها، العيان لما بيعمل ايجاكوليشن ويعمل ايجاكوليشن بعديها بساعه او اثنين العدد بيقل، لكن الموتيليتي بتزيد جدا. فاحنا خدنا الملاحظه دي. طب هل الايفكت ده على الموتيليتي بس ولا الايفكت ده على الدي ان اي انتجريتي؟ ملخص البيبر ديت ان احنا عملنا الكلام دوت فعلا في كيسز وكنترول. ده منظر الكومنت اسين، ده النورمال سبيرم، ده السبيرم ويز هاي دي ان اي دامج. لقينا ان الريبيتد ايجاكوليشن بيحسن الدي ان اي انتجريتي في الناس اللي عندهم اسيلوسوسبيرميا، وفي النورمال انديفيدوال في الكنترول حصل تحسن سيجنيفيكانت في دي ان انتجريتي في السكند ايجاكوليت. وهنا بتظهر نظريه بنسميها ايبيليدمال نيكروسبيرميا. في ساعات الايبيليدمال انفايرمنت بتبقى هوستايل للسبيرم في سيرتن بيشنتس، كل ما السبيرم بيتعرض اكتر للايبيليدمال انفايرمنت ممكن بيحصل له دامج. بيبر تاني عملها زميلنا تامر سعيد مع اشرف اجروال في كليفلاند كلينيك. استعملوا كولويدال لما بيحصل اموتروزس بيحصل اكسترناليزيشن للفوسفورايد سيرين ريزيديوز على الاوت اسايد ممبرين بتاع السبيرم. فاستعملوا كولويدال سوبر ماجنتيك مايكروبيدز ماسك فيها النكسن 5. النكسن 5 بتشبك في ذيس ماركر اوف اموتوتيك سبيرمز، بيعدوا السبرمات على ذيس كولويدال سيليوشن. السبرمات اللي فيها ابنورمال دي ان اي او فيها اموتوتيك سبيرمز تشبك وتعدي للسبيرمز انتاكت دي ان اي. وكان تكنيك هايل جدا وجاب نتائج وحسن نتائج الاكس. ابتدى يظهر عندنا التكنيك الجديد اللي هو الامزي. الامزي في ناس كانت بتترجمه الحقن المجهري الرباعي الابعاد. الحقن المجهري فائق التكبير اكتر، هو مجرد تكبير كبير للسبيرم. مكننا ان احنا نشوف ديتيلز اكتر من ان احنا نشوفها في الاوردينري ماجنيفيكيشن. بنوصل ل 6500 او 13000 مره تكبير للسبيرم. ده منظر الماجنيفيكيشن. بما يمكننا ان احنا نشوف الاكروزوم، ممكن نشوف النيوكليوس ادق، بوست اكروزوم اللامينين، سنتريولز، ميتوكوندريا شيس، تيل. كل الحاجات اللي شفناها ادق. اهم حاجه بنشوفها سبيرم هيد، وفي عندنا حاجه ليها كلوز كورليشن في السبيرم دي ان اي انتجريتي، فاكيوليشن. فاكيول انسايد ذا سبيرم. لما الفاكيول بتبقى 4% او اقل من السبيرم هيد ده انتاكت دي ان اي. لما تبقى كبيره يبقى فيها ابنورمال دي ان اي انتجريتي. هنا بنشوف الروتين اكس سيلكشن. روتين اكس سيلكشن انا بختار السبيرم، هنا الابره بتاعتي بختار السبيرم مطيب بس مطيب. الديتيلز بتاعت المورفولوجي ما بقدرش تبقى واضحه بالنسبه لي قوي. في الامزي تكبير فائق جدا، بنبتدي نشوف ماينور ديتيلز، واهمها الدي ان اي فاكيولز. دي ان اي فاكيولز مهمه جدا ان احنا بنفرق ما بين الابوبتوتيك سبيرمز او السبيرم اللي فيه دي ان اي دامج والنورمال سبيرم. طبعا برضو في تيست او الباترون اللي هو موزون تيست، موتايل سبيرم اورجانيلا مورفولوجي. ممكن نعمل التيست دوت العيان بيفور اندرجوينج اكسي اور امزي علشان نعرف العيان ده مستاهل يعمل زيست تكنيك ولا لا. كده شايفين الابنورماليتيز. بنجمع السبيرم في حاجه اسمها بين، بنجمعه في بحيره في البي في بي بيهدي شويه الروتين بتاعت السبيرم، ونبتدي نشوف الديتيلز ونشوف الفاكيولز اللي موجوده في السبيرم. في كلوز كورليشن بين دي ان اي دامج اند ذيس فاكيولز. لقينا ان احنا بنستعمل تكنيك زي كده بنقلل الميجور فيتال مالفورميشن اللي بتحصل باستعمال الاكزي. بيبقى مشهور 2007 الميجور مالفورميشن قلت من 8% ل 2.8%. هل في تكنيكس جديده؟ بيكسي، اسامي كده بيكسي وامزي وبيكسي. وات ذا مينينج اوف بيكسي؟ فيسيولوجيكال بيكسي. فيسيولوجيكال بيكسي. بنحاول نحاكي اللي بيحصل من خلق ربنا، يعني من وسط 80 مليون او 100 مليون سبيرم يتم انتخاب سبيرم واحد بس عشان يعمل فيرتلايزيشن للاوسايت. ازاي بيتعمل البيكسي؟ الهايلونات is the main component of the cumulus بتاعت الاوسايت. The end of mature sperm carry a hyaluronan specific receptor that enable mature sperm to bind to this hyaluronan. بيبقى في طبق فيه الهايلورونان ده موجود في الدروب، بتبقى درايد، بنعمل لها هايدريشن وبنحط نقطه من السبيرم افتر بريباريشن فيها 100,000 سبيرم. هنا شايفين الدروب اللي بتاعت الهايلورونان. ببساطه شديده السبيرم كل ما كان ماتشور اكتر، كل ما كان دي ان ايه فيه كويس جدا، كل ما هيعمل بايندنج هيمسك في النقطه دي. هنلاقيه بيتحرك في مكانه بس مش بيتحرك، ما بيتحركش، والتيل بتاعه بيتحرك كويس. هنشوف وقت لما التكبير يزيد شويه هنشوف المنظر بتاعها هيبقى عامل ازاي.
1 minute remaining.
بصوا شايفين السبيرم ده ماسك ازاي؟ بس التيل بتاعه بيلعب ازاي؟ شايفين؟ ده منظر السبيرم، ده اللي اختاره. السبيرم دوت دي ان ايه بتاعه كويس جدا، ماتيور جدا، لكن اللي بره دول يعني شكلهم كويس لكن مش ماتيور دي ان ايه ده. الستاديز اللي اتعملت على الموضوع دوت مبشره جدا. Hyaluronic acid binding ability of the human sperm reflects cellular maturity, fertilization potential, selection of sperm for selection of sperm for XZ. Spermatozoa bind to solid state hyaluronic acid, show chromatin with high DNA integrity with actinic orange. DNA integrity مهمة جدا جدا خصوصا في الحالات اللي فيها old age في الفيميل، خصوصا في الحالات اللي فيها repeated failure of
Your time is up.
repeated failure of XZ. مهمة جدا ان احنا نبتدي ندخلها عندنا عشان نعمل ديسيشن صح، نوجه العيان ده انترا انسيميليشن، نعمل له اكزي، نعمل له امزي. اعتقد التطورات الجديده في الاساس الريدكشن حسنت النتائج وقالت لنا السايد افكتس بتاع اللونج ران، واهمها الميجور فيتال مالفورميشن. فاينلي ثانك يو فيري ماتش.
Can start discussion for the first presentation. Any question for Dr. Muhammad Abd?
حس ان ليه مش بقى بيستخدم regularly في ART. Is there a cut-off AMH is there a cut-off عشان حضرتك تحكم على good ovarian user وحضرتك لازم تعملها day 3 of the cycle ولا any day? Any day.
In the presentation, any type of cycle you can measure and graph for more, but T2 and that is the LH that has to be measured at day 3. So we have the option to measure the anti from any cycle. The cut-off limit for full responder is 0.5. If you have a 0.5 cut-off limit, we prefer not to do in vitro fertilization. Once 0.5 and less, this is a very bad prognostic factor.
May I comment on this point? This is very important in counseling the patient. Counseling is a very important part in our work in infertility. So AMH will be a very good indicator for the ovarian response. But from our clinical experience, I think we can advise these patients that you will be a poor responder. The possibility of having a good oocyte is so and so and so. But from my clinical experience, usually they still insist that they should go for a trial. So this cutoff level, you cannot take it as that below this level, don't do XC. But you just counseling the patients. That's very the possibility.
Thanks a lot, Doctor, for your interesting talk. I'd like to ask you, how did you explain the presence of significant relation in serum anti-Mullerian hormone and the absence of such relation in follicular anti-Mullerian hormone and also in the correlation? Thanks a lot.
The antral follicle count is closely related to anti-Mullerian hormone, but the mature follicle is not. That's why you found positive correlation between the antral follicle when we do the ultrasound day 3 and the serum anti-Mullerian hormone. But when we measure the follicular anti-Mullerian hormone, when the oocyte was mature, the was being retrieved, and we take the follicular fluid, the anti-Mullerian hormone at that time does not correlate with the antral follicle. So the expression of the anti-Mullerian hormone is from the follicle 6 millimeters, not 10, not 20, not 30, not 40. What time? It's very difficult to have the antral follicle 6 millimeters. It's very difficult to take follicular fluid from structure of 6 millimeters. But when the follicle is mature 18 to 20 millimeters, it's very easy to puncture the oocyte. You get the oocyte and then you take the follicular fluid.
Our serum AMH reflects the pool of small oocytes we have in the ovary. This is the point.
And we have documented 6 millimeters and 8 millimeters. We will not find that millimeters.
We are concerned about the ovarian reserve. So this serum level reflects the pool of oocytes you have already in the ovary. We are not concerned about the mature follicle. Thank you, Professor Mohammed. For the second speaker, Professor Tariq Hussain, any questions?
Thank you, Dr. Tariq, for your presentation. I had worked on sperm chromatin structure assay in IU cases. We found this correlated with the outcomes. We didn't find that it's not correlated, as you mentioned. But however, the cutoff or DFI to consider bad prognostic or good prognostic, from my opinion, need to be verified, because a lot of consideration in the technique. I see here that use 30% as a cutoff value. What do you think about?
Many papers suggest as a value of 28. Many papers use the cutoff value of 28, but until now, most papers, the agreement, consensus, suggest more to use the 30% as a cutoff value. Yes, semen processing for the assisted reproduction, we didn't test. I don't have one. You tested the DNA fragmentation, more or less. It increases. I think with centrifugation. With the centrifugation only can increase the DNA fragmentation. Yes. But we have to use DNA sperms with better DNA as much as we can. No, I love before. But the standard in the the lab, I can say to the lab to make centrifugation for the specimen and assess the DNA. It can be done in the assisted reproduction. You know, I can't say, send the patient to do semen analysis and say to the lab to do centrifugation and do preparation for the semen sample and then do the integrity. As a research point and as a point we can use it for the lab. If I have one way, I can suggest this. We can know the centrifugation power, RPA power we can use to separate sperm with good DNA integrity to not to damage the DNA more.
In Harrisburg, we don't need to centrifuge the sample. Maybe this overcome the point of centrifugation.
All the techniques of DNA integrity, you can use the centrifugation. I think you use the Agent Orange instead. You don't need to do so. Yeah. Yeah. Yes. But you can do it without processing.
So Muhammad,
my question for Professor Tariq and Professor Ahmed Darwish together. Now we are working in an IVF lab. Which procedure you choose? IMSI or PICSI? Putting in consideration that the IMSI costs around 1,200 pounds and the PICSI, the plate is 300 pounds. We have worked on PICSI in our lab. We have noticed something that very nice sperms, very nice sperms, they do not bind to the drum. And very ugly sperms bind to the drum. So you have to put in consideration, it's not the physique of the sperm. I may be nice looking, handsome, but stupid. And I might be ugly, but genius. So you have to put in consideration this fact. So I need a comment from you.
If you make me choose, I choose those. Yeah, for the
who will pay for it?
Yes, but the MC is not a technique. It is a magnification. It is an extra lens in your microscope. Just magnification. But if there is a technique with many papers saying that it will benefit the patient, I'm obliged. But I can make the patient very less.
If you want my comment in this important question, actually, I should say that we should wait till the test of time. All these techniques now are in experiments for a long time, since 2000, 2002 and 3, and we are, many papers are published about these different techniques. But what we are concerned about is the pregnancy rate, is the outcome, the take-home baby rate. Till now, we don't have a solid data to do these expensive techniques, whether for the lab or for the patients, to say that comparing to the ordinary ICSI, we will have a double pregnancy rate or a double take-home baby rate. That's why we should be very careful in introducing new techniques. And I'll give you an example. The ICSI technique itself, we start to hear about it in 1991, and the first baby delivered by ICSI technique in 1993. In 1994, all the centers all over the world started to use ICSI technique. This means that this technique is very efficient and has a real effect and a real impact on the pregnancy rate. But as long as these techniques are in the market for a long time and not widely spread, this means that they need more and more tests.
There is a point here I can comment on. There is a difference. In my opinion, the end point is not to take home baby. The end point is what baby is going to have help. This baby are going to have congenital anomalies. Are they going to have increased incidence of cancers? Are they going to have fertility problem in the future or not? In the latest meetings, they are stating that we have to wait 2 generations. 2 generations to assure the safety of eggs. Now, multiple publication on the effect of the assisted reproduction on the epigenetic level. There is marked effect on the epigenetic level, on the methylation, on the genomic imprinting. I think this is very important. Does it withstand the test of time?
Of course, in repeated implantation failure, we have to do all what we have in the gap to overcome these problems. Because implementation failure is a multifactorial process. Implantation is a multifactorial process. You have the endometrium, you have the sperm, you have the oocytes, you have the uterus itself. So it's multifactorial, and you should try to correct all the possible factors.
السؤال بس يعني ممكن يبقى منير شويه في التكنيك بتاع البيكسي. How do you get again this stuck sperm? Is it easy?
With the injection needle you can get it easy. Very smooth.
يعني انا ما كنتش متصوراها.
Thank you, Professor Tariq, for this exciting presentation. And now we will move to the third speaker, Dr. Dalia El-Nili. She will address us about molecular diagnosis of azoospermia.
Thank all my professors and colleagues. My talk today will deal with the molecular diagnosis of azoospermia. Azoospermia actually is a disappointing diagnosis for the patient. However, azoospermia affects 2% of the general population and 10 to 20% of men seeking for fertility. Actually, azoospermia to be diagnosed, we have to find no spermatozoa on high microscopic examination, and this should be done on the all seminal sample provided. And according to the WHO criteria or recommendation, centrifugation should be at least for 15 minutes and on a speed not less than 3,000 G. Azoospermia is classified as obstructive azoospermia and non-obstructive azoospermia. Obstructive one accounts for 40% of all cases of azoospermia, which might be due to congenital reasons as congenital absence of vas difference or idiopathic epididymal obstruction. Acquired causes results from infection, vasectomy, or other iatrogenic injuries to the male reproductive tract. While non-obstructive accounts for 60% of all cases of azoospermia, it might be due to primary testicular failure or secondary to hypothalamic pituitary adrenal axis abnormalities. Simply put, can be differentiated by the level of hormones. Azoospermia or obstructive azoospermia is made when there is decrease in the seminal volume and the pH, decrease in the glucosylase activity and fructose according to the site of obstruction, in spite of normal LH and FSH and testosterone levels. When there is a suspected case of complete bilateral absence of vas difference, we need to molecular test this patient. Complete bilateral absence of vas difference, 90% of cystic fibrosis patients, they suffer from obstructive azoospermia. And as we know, cystic fibrosis is an autosomal recessive disorder caused by mutation in cystic fibrosis regulating gene, which encodes for protein has an important role in sodium chloride secretion regulated by cyclic AMP. The delta F508 mutation is the most common mutation in cases of cystic fibrosis, and current recommendation for detection of these abnormalities include commercial ready-made kits, and when the results is negative, sequencer is the answer. And it's worth to mention, in our department there was a study done by Dr. Nermeen Hussain on this topic. When we talk about the secondary testicular failure or hypogonadotropic hypogonadism, which is clinical syndrome characterized by low sex steroids and low gonadotropins level, resulting from absent or defect in normal pulse-style secretions of gonadotropin releasing hormone from hypothalamus, those patients clinically may suffer from anosmia, and this is known as Kalman syndrome, or it may be not associated with anosmia. This usually is a familial syndrome in 50% of cases, and it's rarely to be sporadic. Kalman syndrome was first identified in 1989, and it is due to agenesis of olfactory bulb associated with failure of gonadotropic releasing neurons to migrate from the olfactory epithelium to the hypothalamus. The first gene was described in this condition was the CAL1, and encodes for protein of extracellular matrix known as anosmin-1. More by times, there are more now by 6 genes were incriminated in this problem. The diagnosis is made actually by sequencing. Primary testicular failure, maybe it's due to chromosomal abnormalities. Actually, 4% of males undergoing EGSI have chromosomal abnormalities. 80% of them is involving the 6 chromosomes. These abnormalities could be numerical aneuploidies or structural, such as inversion, deletion, or translocation. Most common are the Klinefelter syndrome and Robertsonian translocations. Klinefelter syndrome, clinically, patients have varying symptoms of hypogonadism and reduced testicular volume. By lab, we find azoospermia. However, less than 8% of the patients may have few sperms in their ejaculate. This associated with markedly increased LH and FSH and low serum testosterone. Karyotyping is the answer for this condition, and as you can see here, there's an extra X chromosome. It's 47XXY gene karyotype. At this point, it's worth mentioning we can have a male with 46XX karyotype. In this condition, the SRY or 6 determinant region of Y chromosome is translocated on the X chromosome. As we said, Robertsonian translocation is a very common finding in cases of azoospermia. In this condition, there is actually centric fusions of the B arms of acrocentric chromosomes, including chromosome 13, 14, 15, and 21 and 22. Y chromosome as a cause of azoospermia, abnormalities in Y chromosome could be macro abnormalities, macro deletions or translocation or inversions, or it could be micro deletions. Actually, Y chromosome is a very short chromosome. It's about 60 million base. The area which involves spermatogenesis is only 23 megabase. The first gene to be identified in cases of spermatogenesis was the RNA binding motif on Y chromosome in 1992, and by 1993 DAS gene was discovered, which refers to deleted in azoospermia, and in 1996, mapping of Y chromosome started, and the area of spermatogenic genes were classified or divided into 3 regions: AZF A, B, and C, or azoospermic factor A, B, and C. In 1999, there was a debate about the presence of a 4th area, which actually, by ending mapping of Y chromosome at 2003, it was discovered that it's only an overlap area between B and C. Y chromosome microdeletion is a very common cause of azoospermia. The international reports 5 to 15. However, there is a wide variation in this incidence, varying the studies. AZF-C region or locus is the most common and represents almost 60% of the cases. Maybe this is goes due to that the AZF-C locus is 4 times longer than the others. How is this genotype is transmitted? We have 6 genotypes of deletions, varying from partial deletion of C to complete deletion of all the 3 loci. And this is translated into either normal semen or partial, in cases of partial C deletion, or to complete absence or what is known as Sertoli cell-only syndrome in cases of complete deletion of A, B, and C. Genetic examination of Y chromosome has entered and become part of routine diagnostic procedure of infertile patients, azoospermic or oligospermic patients, and the sites of this deletion could be simply detected using PCR and the sequence tag sites, which refers to the specific locus. However, it's relatively simple technique, but it was surprising to find that many labs get wrong results, and that made the need for guidelines to include the amplification of a set of primers relating to the specific sequence tagged sites, which identifies 99% of deletion of Y chromosome that is of clinically significance. Actually, by 2004, the European Academy of Andrology and European Molecular Genetics Network put a guidelines. It was agreed by the WHO in 2010. At the end, take home message. Even if detection of a genetic alteration will not substantially change the treatment, genetic testing should be performed for 2 reasons. Why? To finalize the diagnosis and to assess the genetic risk for the offspring in cases of successful treatment. I didn't mention that azoospermic patient with C locus deletion, there is a hope for them to find sperms in their testicular biopsy. That's not the end of the way. They can do an EXI or tesofertil EXI, and so they can hope to have their chance of having a child. But if they have a boy baby, he might have the risk of having this deletion. Thank you.
Thank you, Dr. Dalia. We will keep the discussion at the end of the session.
I would like to invite Dr. Dalia Fresh for giving us a talk about ovarian hyperstimulation syndrome. hyperstimulation in PCOS patients treated with human menopausal parameters. We all know, actually this work was presented in Pathology Fertility Association in Hong Kong, so I took lots of monumental pictures for just for this piece. We all know that ovarian hyperstimulation syndrome is a rare iatrogenic complication of ovarian stimulation occurring during the luteal phase and during early pregnancy. It is potentially fatal and is difficult to predict. Fortunately, the reported prevalence of the severe form of ovarian hyperstimulation syndrome is small, ranging from 0.5 to 5%. So how to predict the ovarian hyperstimulation syndrome? We have three main factors. Mainly first is the risk factors. So PCOS, which is one of the risk factors, young patients with low body mass index, previous history of ovarian hyperstimulation syndrome, pregnancy, and some genetic complications. On the other hand, to predict ovarian hyperstimulation syndrome, some biochemical markers can be used, like plasma estradiol peak, insulin resistance, serum, vascular endothelial translator, and mobility factor, and AMH and more. Thirdly, which is purely gynecologist tool, is the ultrasound and the ultrasound cases with the PCO pattern, the anthropoid count, ovarian volume, low intraovarian vascular resistance. Our aim in this work was to evaluate some predictors of ovarian hyperstimulation in PCOS patients treated with human immunoglobulin. Our subject has subjected to on the third day progressional cycle 33 cases with PCOS to measurement of estrogen, FSH, LH, AMH, leptin, and vascular endothelial growth factor, plus an ultrasound to detect the molecular count. On day 5, an intramuscular injection of human protein, 150 international units, which may be raised up to 235 international units. And then a leading follicle, which is more than 18 millimeters in diameter. At this time, we measure we give another dose of human protein, 5,000 units, and measuring E2 response, which is either below or equal or above 3 kilograms per hour. Out of these 33 PCOS cases, 11 developed ovarian hyperstimulation syndrome, and 22 undergo normal response. According to the level of the E2, which is considered as 3,000. According to the parameter measure, as we said, we measured E2, FSH, LH, leptin, vascular endothelial growth factor, ultrasound count, and AMH, which were the only significant parameter measured as indicated by this is a transvaginal scan showing the anthropoid count. And according to the receiver operating curve, or what is called the ROC curve, receiver operating characteristic curve, the area under the curve for the annual area hormone was 77.77% or 77%,
while the area under the care for the infertility account was 92 or almost 93%. With a significant difference between both the local of the infertility account and the AIH. And there was a positive correlation, however, this correlation was not significant in our cases between the infertility account and the AIH. So we concluded from this study that day 3 infertility account is a better predictor of ovarian hyperstimulation than day 3 AMH level in PCOS patients treated with human chorionic day 3 FSH and H is prolactin and vascular auxiliary growth factors are very critical. Thank you. I would like to acknowledge our team, Professor Salam, Honorable Head, Professor Muhammad Al, Assistant Professor. Thank you.
We have a few minutes for discussion. Any questions for Dr. Dalia? Dr. Dalia, do you suggest this testing to be done as a routine? And if so, how much it costs? The molecular.
Yes, it's one of the guidelines outside guideline for routine work for cases of azoospermia.
Severe olive.
Azo or severe oligosperm. Less than 5 millions or may start this test.
How much?
It's cost it's almost nothing compared to eggs, which are thousands, only a few hundreds pounds for this test, giving the results which may indicate that the patient will not be a candidate for EXI, and so he will save his money.
And it is available.
Yeah.
Thank you. Any more to say?
Dr. Ahmed mentioned a very important point regarding the oligospermia. We have the increase in FC is a progressive gene. Today having 5 million, after 1 year 2 million, after 1 year azo with sperm in the testis, after 1 year no sperm in the testis. If you catch such patient, you have to make cryopreservation. This is very essential.
ده اللي احنا بنقول لكم ابعتوه لنا بدري ما تروحوش تعالجوه كتير.
بس بعدين نعمل اسئله الاول بس.
Thank you, Dalia. Our last speaker, Dr. Dalal. Any questions for Dr. Dalal regarding ovarian hyperstimulation syndrome predictors? Already taken. Thank you very much. Thank you for Dr. Wafat. Thank you for the audience. Thank you for the speaker.